Thank you. At Addiction Policy Forum, we are building a patient advocacy organization for the patients and families that are struggling with substance use disorder. It's been an interesting road, learning from other disease spaces and other patient groups. Like even the rare diseases have had a patient advocacy space, and then the rare diseases have like another, single organization for all the rare diseases. And we have a lot of people that are in recovery, a lot of people currently struggling. Lots of families. This is a family disease. It feels like it hits your whole family. And so bringing those together and helping to navigate a new path is our mission. Sort of my takeaway and some of our input is, one, we have a real concern about pitting patients, one patient group versus another, that we need to sort of look at this from a broader viewpoint to make sure we don't have unintended consequences. And there's a lot of oversimplifying. Addiction is complicated, right? And I think when we try to oversimplify this, we end up getting in a little bit of trouble. And I've seen this over sort of our work in this area. We tend to play whack-a-mole with the drug du jour. So when I got involved, it was heroin, and then it was cocaine, and then it was crack cocaine, there was methamphetamines, it was prescription painkillers, then heroin, and now synthetic opioids. The reality is we have a problem with substance use disorders, and most people, we have a problem with polydrug use. We also, I think, it's so much simpler to go with the 6 o'clock news version of how we got here, or to talk about the root cause in really simplified ways, that this begins in a doctor's exam room. But addiction doesn't begin there for the most part, right? The root causes piece is more complicated than that, and takes more people at the table to fix it. Bob and I are bonding over one piece, so we didn't compare notes beforehand. I sort of explain this as two components of root cause and how this develops. One is our social norms culturally are changing in the not right direction. We talk about 20 million people that are struggling with addiction today, but 15 million of those 20 are struggling with alcohol use disorder, right? And our cultural norms and our usage of alcohol, that is not reducing. We are changing policies when it comes to marijuana. Some of the work that in progress we've made on tobacco now feels like it's slipping a little bit among our adolescent populations because of vaping and juuling and other things. So I think that we have to remind ourselves that this is an adolescent brain disorder. This is a disease that begins in adolescence. And unfortunately, we typically treat it in adulthood. So think about that. Like, this is one of the only diseases that we wait for it to get worse before we intervene. One of the pieces that we talk about, we have this list of, when it comes to addiction, of comparing it to any other disease we can find to get people to really understand that this is a health condition, because we're not there yet in the entire country to really understand that this deserves a healthcare response. And so I think we need to really understand that. And the second part, where Bob and I agree, is that we have a problem with trauma, right? Adverse childhood events, sort of intergenerational substance use disorder, understanding risk factors in a different way. Not everyone has the same risk factor for a substance use disorder. And this is like an interesting maybe tie-in into some of the things that we're working on or we would like to see. We need to do a better job of understanding where that risk is, understanding genetic predisposition. When I talk to folks and everyone's like, I don't know if I should take this medicine, I might develop an addiction. I'm like, well, let's do a different type of history taking. Tell me about, does addiction run in your family, right? Tell me about your age of initiation. Did you start using alcohol, marijuana, and tobacco at 12 or at 20? Right? Because we know from the cross-sensitization studies that age matters. Age of initiation matters. We need to talk about this in terms of brain development. Tell me what your patterns are, and don't fib about your marijuana and alcohol usage, because we have this myth that we put the opioids in a different part of our brain than we're putting the marijuana and the alcohol. And I think we need to do a better job of explaining and teaching our patients about what that risk really looks like. So so much on sort of doing a better job of the risk thing. On the ACEs side, we know that there are some real concerns, and we have so many things that we can be doing differently in addressing early childhood trauma and addressing it earlier, right? Instead of sort of like burying our heads in the sand and hope that everything works out. We know that this has long-term health consequences for our patients who struggle with early childhood trauma. So how do we start intervening earlier? Because this is a main component. A few of the other things in terms of our wish list or what we're working on at APF is we need to integrate the treatment of our illness into healthcare. So we need to find doctors when we're struggling, and you all, instead of a really fancy place in Arizona that's going to charge us $40,000 and offer us a plane ticket. We need to find physicians that are going to help us manage a chronic condition that we need help for years and not 28 days to manage. We need to prevent this. This is a preventable illness. Age matters. We talk about prevention is about delaying the age of onset. And I don't think we're doing the components that we need to have pediatricians and primary care physicians and family physicians having the components they need to teach the parents as well as their patients in their adolescent years how to protect themselves from this illness. And then finally is this early intervention piece. Really tackling having early detection and early intervention when this disease begins instead of waiting. One of the pieces we just put out is, and it seems like a common sense, but don't wait for rock bottom. It isn't that we have a lot to teach. We have a lot to help people unlearn when it comes to this illness. We don't wait for stage 4 before we treat cancer. We don't wait post-amputation before we initiate treatment for diabetes. So why is it that we have these ideas within our culture to distance ourselves or for wait for the worst possible thing to happen when our patients are struggling with a substance use disorder? Overall, and time is up, but I think that we can make progress by actually using the knowledge that we currently have on the table and implementing it better and taking it to scale. We can make progress without choosing between patients because we have real concerns about unintended consequences when we swallow the oversimplified explanation for a very complicated disease.
Thank you, Jessica. That was very compelling. I know training may come up again here. Dan.